Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians. Practice medicine the way you've always wanted. Data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of VillageMD. It's my absolute pleasure to be here today with Megan Harkins. Megan, how are you?
Hi, Wendy. Doing well. Thanks so much for having me.
We've been talking a lot about lately, you and I, really over the last, 3 years, about a theme that we're dealing with in terms of being healthcare regulatory lawyers. And we just wanted to talk to our listeners today about this thematically. It's a little different than the kinds of things we usually talk about. But the thing that we're dealing with and seeing throughout a number of different areas is just a convergence between clinical care and regulatory requirements, mostly around billing. And the care and the billing have converged in a way that I think is affecting a lot of different roles in healthcare. Megan, this is a topic that we've kind of touched on before, but we really haven't talked about the convergence of clinical care. We've talked about how payment has evolved. We know that it started as a charge for a service. Then that became such an inflation in charges that they came up with these very complex bundles, which are in some cases really based on the clinical condition. The best example, hospital DRGs. The patient's condition is coded, and that's affecting the reimbursement. The idea for that is you need more time and more resources if someone is sicker. But the DRG puts a cap on the total episode of care. So the idea would be like, okay, if you have this condition, you get $100. But if you only have this condition, you get $50. So the condition itself, the clinical condition, becomes very relevant then to the payment. And suddenly that becomes important in the revenue cycle and billing area in a way that it hadn't before.
There seems to be this very healthy tension between what is reimbursed, how it's reimbursed, and the care that then the patient receives.
So yeah, exactly, Megan. It becomes this tension between the coding, billing, and the care. And then now going into value-based care, bringing Medicare Advantage is really bringing that same concept into the physician office, which is now being paid not just based on the time and the amount of effort, which was a E&M code, but really based on the clinical condition, which is what we call the HCC code. And it's a diagnostic code. It's a good thing. It's the right way to do it because the idea is if a patient is more complex, they're likely to have a higher expense and you need to spend more time with them. But it requires a different type of diagnostic effort and diligence around diagnostic effort that a physician like Laura Ingalls' doctor that came to her house really didn't have to make sure he wrote down exactly the diagnosis. He kind of knew what it was in his head. He didn't have to record it. And then it wasn't numerical. So he didn't have to know the exact right number. And, so it just gets kind of weird to converge these two. And it just creates a lot of change that you can't really underestimate how impactful this convergence has been.
Because in the past, Wendy, right, you were able to separate more cleanly billing and clinical, but now it's sounding like it's an advantage to have a clinical person do the billing and for the clinical folks to have some knowledge of billing and reimbursement, although that may not feel like part of their role, but because the two are so closely tied that in order to get the patient the services that they need, you almost have to have that background of what the billing requirements are so that you are accurately stating.
Yeah, it's almost a language, and you're right that in the beginning of my practice, I feel so old saying that, but it was very separate. And there were clinical people, there were billing people. The clinical people did not want to get involved in the billing a lot of times. In fact, it was almost morally, we kind of care for all patients. It was very separate. The billing people were very disconnected from clinical conditions. They weren't involved in it in the same way. So for example, a social worker would write a note, the billing person would just send out the bill. Now, sometimes it did cause problems, but for the most part, they were disconnected. And what ended up happening, and this was like something that was hard for me to learn because as a young lawyer, I tried to, I had this idea that I was going to sit down with, at that time I was working in a hospital. I was going to sit down with the different people in the departments and start to explain to them, what were the billing rules that applied to their work. And so I printed out all these national coverage guidelines and things. And I just thought they would just be interested to know. And this would be like nurse managers or nurse leaders. And so I would sit down with them and I would go, okay, here's everything. And I had people literally say, okay, I don't need this meeting. I'm not staying here. I don't need to know any of this. And
You were hoping for the aha, and then you gotta, don't talk to me.
I
Instead.
just thought it was so cool and like helpful. And a lot of times people go to these outside, there's a bunch of different outside things that people use to help them determine if care is covered. But I always felt like you don't need that. You could just look right here. Medicare has this database of all these coverage guidelines. And I just feel like everyone should, like, if you're working on a dialysis unit, everyone should know this. But it was just culturally, it was just a big barrier. Clinical people did not want to know it. And the billing and coding people, like, usually were not even in the building. They weren't around. They were, just very focused on a charge and a service, and that was it. So it was a very hard lesson for me. Looking back, I think I was thinking of the future and not realizing how important it would be. And I think in another way, the laws were already starting to be there, but the people, the change really had not taken hold yet. And
this seems risky, having, the right hand and the left hand not meeting one another, not talking with one another, especially previously when technology wasn't quite what it is today.
Yeah, it did cause problems. And we gave the example of the social worker does a bill and the coder drops a bill for psychiatric care because the coder doesn't understand, the social worker doesn't do psychiatric care. That kind of disconnect, you did have problems. And back then, we didn't get continuous feedback from Medicare like we do now. So you could have a problem. And I had a client that had a problem, went on for 20 years. The billing is now in the multi-millions. And they did a 5-chart review, 100% error rate, and then a huge extrapolation. And it just became, this terrible thing. So even though the codes and things were different, they weren't as clinical, the separation was still problematic, which is why I was always trying to bring people together to understand that. But the change just hadn't really taken hold. And, kind of unrelated, but a lot of times you hear people talking about private equity in healthcare or venture capital in healthcare. And this is one of the things that I wish I had the right way to communicate and we could advocate for, because bringing this kind of cultural change is so hard. And it requires such an investment in training, technology, data, and then repeat. It does require a different way and a new approach and a fresh look. And, I like to think about lawyers. Imagine if lawyers suddenly got paid based on how serious was their client's problem. You had to code, okay, this is a employment discrimination case. This is a bad one. So it's 2.2-9, real bad. Like lawyers understand that right now. They kind of know how bad a case is, but they don't have to describe it in a code to get paid.
Right. I think of like our alternative fee models similar to our attempt at episodic care. And there are certain repeatable tasks or requests that you can easily assess in advance what that cost is going to look like. But it is a shift, and it's a necessary
shift. Imagine like lawyers doing that. It would just be a huge change. And like they would not want to connect their assessment of their case with the rate they're being paid, And so that's the change that we're in the middle of. It's sometimes helpful to think of it in another context to really get perspective. as to what massive change it is.
So Wendy, what kind of changes are causing this shift, this convergence of billing and clinical?
There's so many, and I kind of think of it into three separate categories. The first one is the one we talked about, which is the clinical diagnosis is the basis of payment. That is a huge change and it requires all kinds of changes. And that's obviously the biggest one, but that's not the only place that this is coming. The other one is all these pre-approval and conditions of payment. So Medicare has a whole database of them. And like in the 80s, you never saw these. They really started to proliferate after like in the 90s and now. And they're very, very deep, and they only get more detailed. In some cases, they actually drive preventative care. So like and this happened for the first time, like maybe 5 or 7 years ago, to get certain type of orthopedic surgery, your physician had to show that they tried A, B, C, D first. And, those kinds of like clinical almost protocols became conditions of payment, which was a big change. And it does now drive how treatment is provided.
And it's got to be so frustrating too for the patient to sit and wait for the ultimate potential treatment that is what they needed all along to feel.
Yeah, you'll hear patients say like, oh, I have to go through this so I can get my surgery. You do sometimes hear that, but for the most part, these are based on very well settled standards of care. It's just hard when you have to apply anything to a number of people. And then the last thing is another trend that's related, which is it used to be a false claim was you didn't perform a service that you billed for, or you said that you did it longer than you did, or you diagnosed a patient overly aggressively. But a new area of false claims that's just emerging in the last few years is the idea that you performed a service that clinically wasn't necessary. We started to see that, of course, in labs. That's a little bit easier in labs because you can take a vial of blood and do so much with it. But it's moving into even procedures and surgery where we're seeing indictments and prosecutions for medically unnecessary cardiac stents is a big area where you see this. Now, most of the cases are very egregious and they're sort of shameful in some ways, but as a theory of false claims, it's another place where the claim is being connected to the care that's being performed.
And Wendy, this totally harkens back to an earlier episode that we had where, this is why we can't have nice things, because you've got these folks who take advantage of the rules. And then after some enforcement, we then see the rules change, which then could influence or affect how the clinical care is able to be delivered.
Right. And then compliant people have all these more rules they have to follow when, they were trying to follow the rules before. And of course, people that are non-compliant still do whatever they want. So it does create this policy conundrum that I think about a lot, which is like, sometimes the rules aren't really helping. But then again, the reason they make them is because of all, non-compliant.
Somebody found a loophole or they tried to break them.
Right. That's right. So, but these are really the three areas, one of the things that's a massive change and very disruptive and confusing, and even for our providers, is these hospital observation and 2 midnight rules, and just getting a patient into a hospital has changed significantly. And the change was so massive that even medical records weren't designed to handle it. And so you didn't even have the right codes for things. But some of that is settled down now. But it's just another example of where the care you want to provide is so dependent on the billing requirements.
And in turn, too, the billing requirements have to reflect the care that needs to be provided. It's this, you can't separate them anymore.
Right. That's right. So it's, as I said, it's the reason why we're so proud to be at VillageMD, and the investment that we're making in technology and data and training to kind of bring people along, and just the appetite for change and a willingness to think differently about the way that a lot of different roles are performing is such a refreshing thing to be at VillageMD. Many times in healthcare, people are very, and like in any industry, they're very driven and they're very hardwired into an old way of thinking. And to really make this change, it's new roles, it's new communication, it's people who speak both languages. They speak clinical, they speak billing, and it's a major adaptation and process that we're going through. We've been in it a while, but we're still in it.
Major, but absolutely necessary to change the system of healthcare to reflect what our patients need, but then also to reduce the total cost of care.
I think it's the right changes to make, and I think it's valuable. I think it's a strategic advantage for VillageMD just because we have the culture of openness and innovation. But it's definitely, even for an old regulatory lawyer, it's definitely a constant growth mindset is needed. Well, Megan, thank you so much for joining me and talking about this. We've had this conversation so many different times. I hope our listeners appreciate the perspective. We always like hearing from our listeners. So you can contact us on LinkedIn or Twitter, or by email. Just, we love hearing from you. We've got a bunch of new and exciting changes coming up to talk about, and we look forward to having you join us in our next episode.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.